So welcome. I'm Dr. Mark Skeen. I'm an associate professor of neurology at Duke University Medical Center and work in the multiple sclerosis clinic there. This is another in a series of videos hoping to inform whoever's interested regarding issues in multiple sclerosis and its management. So the topic of this video is PML, progressive multifocal leukoencephalopathy, and I'll describe that. And how our concern and our fears over PML influence appropriately and inappropriately our decision making regarding choice of disease-modifying therapies. So first, PML, and I'll keep using the abbreviation because progressive multifocal leukoencephalopathy is too hard to say very many times, is a terrible condition. So I don't want to make light of the seriousness of PML, but I do want to put it in perspective. So living in most of us, or all of us, is a virus that we call the JC virus. And it lives somewhere in our bodies, perhaps in the bone marrow. And for most of us, we live our entire life not knowing it's there and not caring that it's there, because it lives there and mostly does us no harm. It's a complicated virus to study. We're learning more about it all the time, but not enough. And we don't really understand a lot of the crucial aspects of it. The virus that lives in most of us can't do us any harm. And it requires multiple steps or multiple things to go wrong, sort of the perfect storm, for this virus to cause PML. I'm going to describe that a little bit. So what happens in the right setting is that the virus can mutate from the form that it is in most of us to a pathogenic form. And then it can gain access to the central nervous system, where it causes a disease that's much worse than multiple sclerosis. To do so, we generally have to have some problem with our immune system. We have to be immunosuppressed, such as having HIV or AIDS or taking powerful immunosuppressive drugs. And with regard to MS in particular, that's true with natalizumab or Tysabri. And it's a terrible problem. It does a lot of damage in the brain unless it's caught early and can be reversed. And so it's a very significant issue. What I would say is, and I'll try to say why in this video, is I think we're much too worried about it, however. I think it needs to guide our decision making, but it probably should not play as big a role as it does for most doctors and certainly most patients. And I'm going to try to explain why that is. But just to understand that this is a progressive problem that results primarily from a defect in the immune system that can be caused either because of other diseases or because of the medications we're using. And it happens in a small number of people who have those conditions. And we're going to talk a lot about that. So I mentioned 3 steps: mutating into a pathologic form, gaining access to the brain, and having an inadequate immune response to control that. There probably are several more things that have to go wrong in order to get PML, and that's why it's infrequent. So what I want to talk about a little bit is numbers and the frequency of bad things happening. So I think it's very appropriate to think about what the chance of getting PML is when we are considering therapy with Tysabri or natalizumab. Why? Well, when the medication was first released back on the market after we recognized that it was associated with the subsequent development of PML, our understanding was that 1 out of 1,000 people who took Tysabri for years would develop PML. And depending on your point of view, that's a terribly scary thing. Tysabri is also an incredibly effective therapy for multiple sclerosis. And so the other way of looking at that is that 999 out of 1,000 people who took Tysabri would get a very, very remarkably effective therapy, and one person would get the PML. And so the trouble is we couldn't tell who that one person would be. So at that time, most of us considered that it was still a very useful therapy for those people at highest risk from their MS, but probably not most people whose risk from MS was medium or less. And that's generally how we used the medication. We've subsequently come to believe that a blood test, the JC virus antibody index, however, can help us do better. That those folks whose JC virus antibody index is negative or low have a very low risk of developing PML. That is, and those folks who are positive have a higher risk of developing PML. And that's true with an exception, and that is that folks who've had previous immunosuppressive medicine are effectively all at higher risk. Most of those are not medicines we use much in this country, not the medicines that are approved for multiple sclerosis therapy, is what I mean, but are used for other conditions or have been used in the past when we didn't have so many FDA-approved medicines. So potent immunosuppressive therapy raises the risk of PML from Tysabri. But in the absence of that disqualifier, we think that the JC virus antibody index stratifies the risk of subsequent development of PML so that folks whose JC virus antibody index is negative or low probably have about a 1 in 10,000 chance of developing PML. And I'll explain that further. And people whose JC virus antibody index is high and they use it for years probably have as much risk as 1 out of a few hundred. So what does that all mean? Well, first I should say that talking about numbers always gets confusing. And it may be obvious for listeners, but studies show that we don't understand these kind of fractions very well, so humor me here. So if we say that something occurs 1 out of 1,000, that means if there were 1,000 people in the room, 1 of that 1,000 might have the problem. And if we say 1 in 10,000, that means if we had 10 of those rooms with 1,000 people, in 1 of the 10 rooms, 1 person would have the problem. So what I'm trying to say is the larger the denominator, the less frequent the problem, if that makes sense. So if I have a chance of something bad happening 1 in 100 or 1 in 1,000, the 1 in 100 is 10 times more likely than 1 in 1,000. So that may be obvious to many, but research shows it's not obvious to many in our country. So I wanted to clarify that. So let's try to gain some perspective. So we talked in previous lectures about that PML has also been seen with a lot of other medications, including 2 of our other FDA-approved multiple sclerosis therapy, Gilenya and Tecfidera. With those drugs, the best estimate I could give you would be that the chance of developing PML is about 1 in 30,000. I'm really talking round numbers here, so if you quote me, please say I guesstimated. But the point is that that's a very unlikely event. So for everybody in this country, you need to know that your chance of dying in a car accident this year is 1 out of 4,000. Dying in a car accident is 1 out of 4,000. So 1 in 10,000 risk of developing PML is 2.5 times less likely than your chance of dying in a car accident this year. Doesn't mean it couldn't happen. Now, if you text and drive and do all sorts of things, you can make your risk higher. And if you don't do those things, you can probably make your risk lower. But for the average person on the road, your chance of, in this country, your chance of dying in a car accident this year is 1 in 4,000. Your chance of getting struck by lightning is somewhere between 1 in 5,000 and 1 in 8,000. And if you're a woman in this country and you get pregnant, your chance of dying during pregnancy is between 1 in 5,000 and 1 in 10,000, just from being pregnant. What's my point? My point is to try to put some perspective on the risks of PML with our MS medications. In other words, for all of our medications with MS or otherwise, if we're considering the risk of PML, with the exception of Tysabri or natalizumab, the risk of getting PML from any of our medications is much less than the risk of everyday life events, including pregnancy. So it is a more dangerous thing to get pregnant than it is to use one of our other MS medicines for MS. That's the reality. Now, Tysabri or natalizumab is the single exception because the incidence is higher, 1 in 1,000 or 1 in 500 maybe for all comers. A lot of these numbers can be skewed in one direction or another depending on how they're phrased and how the data is looked at. My goal is not to quibble but to give perspective. And what I would say is that after the first year and a half of therapy with Tysabri, which is when the risk starts to increase, if the JC virus antibody test is negative or low, the risk of developing PML is less than or equal to the everyday risks of life that we just spoke about earlier. And to me, if you can take a very powerful medicine for a very risky disease, and the risk of that medicine is less than or equal to the risks of everyday life, that still seems like a very reasonable choice. It actually is the choice I would make, but not everybody agrees. On the other hand, if I was JC virus antibody positive, very high, the risk gets to as high as 1 out of hundreds. And then I really wouldn't want to take that risk. It was much higher than the risks of everyday life. And then I really wouldn't want to take that risk unless I was in a desperate circumstance where nothing else worked or my MS was terribly aggressive. And we do see that on occasion. So, in summary, what I've tried to do, hopefully with some success, is just to put some perspective on PML. In honesty, I think we, doctors and patients, are way, way, way too worried about PML. I think it's very appropriate to think long and hard about the risk of PML and what we know about it when trying to make a decision about whether or not to use Tysabri or natalizumab. I think with our other medications, the risk is so low that we should, if we talk to our patients about the risk of PML from Gilenya and Tecfidera, and we don't talk to them about the risk of not wearing seatbelts or texting and driving, we've really done them a tremendous disservice. We've really been irrational about how to best take care of our patients. So I hope it's helpful, trying to give some perspective to PML, not to minimize how serious it is, but to help put perspective on how frequent or likely it is. And it's less likely in the vast majority of circumstances than everyday life risks. I hope that's been helpful, and we'll continue to have further videos and further conversations. Thank you.